Hi, my name is Lindsay Cuellar, and for our 152A project, my topic is Relative Energy Deficiency Syndrome in female athletes, also known as REDS. For a little bit of background information, what is REDS? REDS is the abbreviation for Relative Energy Deficiency Syndrome. People with REDS have impaired physiological function due to an imbalance in the amount of energy being expended in daily living, sport, and caloric intake. REDS includes, but is not limited to, disordered eating, hormonal imbalance, metabolic imbalance, energy deficiency, bone structural injury, decline in performance ability. These are the subtopics that I'm going to focus on for my REDS presentation. What is a female athlete triad? Female athlete triad was a common term used before REDS was introduced. Female athlete triad limits the issues of REDS to females, while there are more and more cases being found of REDS in men as well. Female athlete triad refers to a female having an eating disorder, amenorrhea, and osteoporosis. These are the three sides of the triangle. They do not have to have all three symptoms present, but most develop more than one. In 2014, the International Olympic Committee working group coined the phrase relative energy deficiency syndrome to emphasize that syndrome affects all athletes, not just females. However, the Female Athlete Triad Coalition has refuted the IOC 2014 consensus statement beyond the female athlete triad relative energy deficiency in a published article in the British Journal of Sports Medicine. The coalition feels the new IOC statement does not place enough emphasis on the female athlete triad model that has been previously researched and improves the health outcomes of female athletes. So as you can see, some organizations are not happy with the fact that female athlete triad is going away and REDS is being introduced. A lot of the articles that I'm going to refer to will flip back and forth between the terms of REDS and female athlete triad. They are not synonymous because of the male and female aspect, but they are very similar. The first thing I'm going to talk about is disordered eating. Many athletes have some variation of disordered eating, some as serious as being clinically diagnosed and having life-threatening side effects. The prevalence of DE is about 20% and 13% among adults and adolescent female elite athletes, and 8% and 3% in adult and adolescent male elite athletes, respectively. The prevalence differs significantly among sports. The disordered eating continuum starts with appropriate eating and exercise behaviors, including healthy dieting and the occasional use of more extreme weight loss methods, such as short-term restrictive diets. The continuum ends with clinical eating disorders, abnormal eating behaviors, distorted body image, weight fluctuations, medical complications, and variable athletic performance. Some practical abnormal eating behaviors, such as fasting, binge eating, purging, or use of diet pills, laxative, diuretics, and enemas. The DSM-5 has found EDNOS, eating disorder not otherwise specified, to be most prevalent. Where the individual manifests with some disordered eating behaviors but fails to meet the criteria of anorexia nervosa or bulimia nervosa. Common signs and symptoms associated with disordered eating are found in both of these. Hormonal, metabolic imbalance, and energy deficiency. Some athletes are not considered to have an eating disorder, but do not meet their minimum energy needs because they are expending so much during exercise. The fact is, athletes are unaware of how much they should be eating and when. Low EA, or energy availability, can occur with or without an eating disorder. Unintentional low EA is due to a lack of knowledge on the part of the athlete. She is simply unaware of the amount of daily calories she needed to offset her training and normal bodily functions. According to the Journal of Sports Science, skin folds and urinary ketones may be the best biomarkers of fat stores and carbohydrate deficiency, respectively. In a study done by Deutz et al., the average energy intake for all athletes was around 1,600 calories, and the average predicted energy usage was around 2,384 calories, resulting in an average energy deficit of 784 kcals over 24 hours. In the study, they analyzed a combination of elite-level runners, elite-level gymnasts, recreational gymnasts, and rhythmic gymnasts. The highest amount of energy deficit daily was found in female gymnasts. The gymnasts had the largest inadequacies, both for 24 hours and within 24 hours. Rhythmic gymnasts had the largest daily energy deficit. The largest energy deficits occurred, regardless of athlete group, immediately following their afternoon training session. In these athletes with the large energy deficits, it was positively associated with percent body fat. With either skin fold derived or DEXA derived body fat percentage, the more pronounced the daily energy deficit, the higher the body fat percentage. This data should discourage female athletes from practicing restrained diets or delayed eating. Low energy availability can also lead to amenorrhea in young female athletes, which can cause long-term reproductive problems. When EA falls into a negative balance, the body reacts by reducing the amount of energy needed for bodily functions, such as cellular maintenance, thermoregulation, and reproduction. The shift in energy distribution is not without negative consequences, as it impairs overall health. Amenorrheic women experience infertility, as they do not develop ovarian follicles or ovulate. As the number of female athlete triad or REDS factors increases, so does an athlete's risk for bone structural injury. A study done by Barrick et al. In 2014 found, in the sample, which included female adolescents and young adults participating in competitive or recreational exercise activities, the risk of bone structural injuries increased from approximately 15% to 20% for significant single risk factors, to 30% to 50% for significant combined female athlete triad-related risk factors. In the combined sample, 28 participants sustained a bone stress injury, consisting of 17 stress reactions and 11 stress fractures. This information tells us that the more female athlete triad symptoms or RED symptoms you have, the more likely you are to experience a stress fracture or a bone-related injury. Adolescence and young adulthood is a time of maximal bone mass accrual. A lack of maximal bone acquisition may result in osteoporosis later in life. Most bone mass for women occurs around 19 years old. Even silent estrogen-progesterone imbalance, as seen in subclinical ovulatory disturbances with low energy availability, may produce negative changes in bone. How does this affect an athlete's performance? They're doing all this to try and improve their performance, but it's actually doing the opposite. Athletes not consuming enough calories are putting themselves at a higher risk for injury and illness. Many athletes try to become thinner to improve performance or to look better in their ecstatic sport. But if they are not consuming enough calories, they end up with low energy availability and declines in performance. Athletes who suffer from long-term low energy availability may develop nutritional deficiencies, including anemia, chronic fatigue, and increased risk of infection and illness, all of which have the potential to harm health and performance. How do we treat this? To treat an athlete with RED-S, it is extremely important for them to have a very individualized treatment plan that fits their specific needs. Every case is different in some way, so it is important to address each case with an open mind. Some may need a referral to a psychiatrist, while others with unintentional low EA may just need to see their primary care physician or a dietitian. According to Nissenbaum-Hammer, through the recovery process, the athlete needs to feel respected and that their feelings, thoughts, and opinions about the recovery process plan are valued, with a team of experts working collaboratively with each other and the female athlete. The goal of resuming a healthy lifestyle, including successful participation in sport, can be achieved. The goals are plain and simple. To make sure the athlete is living a healthy lifestyle. That is the number one. We do not want to see female athletes having negative side effects for the rest of their life. However, treatment of RED-S has proven extremely difficult and at times ineffective. The best way to treat this disease is with the preventative measures for athletes in all sports. That is why these are my recommendations. It would be helpful for all teams to invest in a registered dietitian to inform athletes of the proper amount to eat, when, and what type of food they should be eating. Athletes should not be pressured by coaches to lose weight without the knowledge of how to do so safely. Many coaches right now tend to tell athletes, "You're heavy, you need to be lighter." But this is not helpful. Coaches should also be educated on the signs and symptoms associated with RED-S in order to identify it early. And most importantly, screening for the triad should be undertaken as part of the pre-participation physical evaluation on an annual basis at both the high school and collegiate levels and at private sports. For those who have suffered from the female athlete triad or RED-S, should be helped in a very individualized manner, depending on what they are suffering from. Psychiatrists, doctors, and dietitians should be brought in as necessary. Why did I choose this topic? This topic is very important to me because I was a female gymnast for 13 years and experienced firsthand the pressures to look better, to be lighter, to perform better. Especially in gymnastics, coaches tell you the skinnier you are, the lighter you are, the easier it is to flip your body. But that doesn't help you if you're so weak you can't do it. During my career, as young as 12 years old, I was measuring my percent body fat weekly and keeping a diet journal. I was never referred to a dietitian to help me choose what I eat. I was just told I was too heavy. I believe this issue has a heavy impact on females in aesthetic sports and needs to be addressed before girls start having these potentially life-threatening problems that will follow them even after they leave the sport. Now, I'm not saying this is not a problem with males as well, but for my presentation, I focus specifically on females and mostly in aesthetic sports. Here are my references. Thank you.